As we discuss gynecological infections, what I want you to see is that there's a spectrum of diseases, of infectious organisms, that starts at the vulva and gets worse the higher you go. So I want to show you what that looks like so we have some sort of idea before we begin. Uterus, ovaries, vagina. So what you'll see at the very opening, the lower end of the genital system, is vulvovaginitis. This is going to be Trick, BV, and Candida. As you get a little higher, you're going to cause a cervicitis. This is sort of a transition point between vulvovaginitis and PID. Cervicitis is generally caused by STDs like gonorrhea and chlamydia, but can be caused by the same organisms that cause vulvovaginitis. And then, as you get even higher into the genital system, you can start developing diseases like endometritis, salpingitis, tubo-ovarian abscesses, and then frank peritonitis. And the idea here is that the higher up the infection, the more severe the patient presentation. The cervicitis can lead to an infection that ascends into the uterus, but it can also break down the protective lining of the uterus, allowing those vaginal flora to ascend. But generally, those organisms that cause vulvovaginitis can't get past the cervix. You'll see how this becomes relevant as we talk about each of the diseases. We're going to start off with vulvovaginitis, the most benign of the diseases. And what you need to do for vulvovaginitis is recognize which organism is doing the infection based on the patient presentation, which includes the vaginal discharge and what you see on a wet prep. And knowing what the organism is, you'll then be able to treat. Now, everyone's going to get a speculum exam, and everybody is going to get a wet prep. And a wet prep is both a saline prep and a KOH prep. You're going to take a swab of the vaginal discharge, put it on one slide with KOH. You're going to take the same swab, put it on another slide with saline, and then look at them both. Both are going to be done every patient, every time. And we're going to break it down into 3 different infections. The first being Candida. The person is going to have risk factors for developing Candida. That is diabetes, steroids, or recent antibiotic use. And the patient is going to have vaginal discharge and a little bit of itching. When you look, what you'll see is thick, white discharge that's adherent, it's sticky to the vaginal wall. And there's generally going to be no odor associated with Candida. When you do the wet prep, what you're going to see is hyphae. Hyphae are seen on the KOH prep. And the treatment is going to be antifungals. And for antifungals, you're first going to use over-the-counter topical, and if that fails, you can use prescription fluconazole oral ×1. That's Candida. The next is bacterial vaginosis, and BV is the most common cause of vulvovaginitis. What you're going to see is that itchy discharge, but when you look with a speculum exam, what you're going to see is a thin gray-white discharge, and you're going to see a lot of it. It's copious. It has a fishy odor. And this is a perfect example of why you do both a KOH prep and a saline prep, because the diagnosis is going to be made by seeing clue cells on a saline. But if you do the KOH prep, you'll have a positive whiff test on KOH. The treatment here is going to be with metronidazole. And you'll try topical first, then move to oral. And lastly is trichomonas. And trichomonas has a phenomenon called ping-ponging. The idea here is that you are only treating the woman. So she comes in, you identify trick, you treat her for the trick. But her partner still has it, and she then gets reinfected by him. And if he gets treated, not at the same time as her, she'll give it back to him. So if you see repeated infections of trichomonas, it's because you're not treating both partners. If you look with a speculum exam, you're going to see a yellow-green frothy discharge. And you might see cervical erythema, so-called the strawberry cervix. You will see organisms that have flagella and they're motile. They're zipping around the slide as you're looking on a saline prep. This is also treated with metronidazole. But unlike the other ones, it starts off PO, and you must treat both partners. And they need to be treated at the same time. Otherwise, they're going to continue to ping pong. So the idea here is that all of these are going to present with some sort of vaginal itching. You're going to do a speculum exam and take a look. You're going to take a wet prep. If you see what the diagnosis is based on either the discharge or the wet prep, you just treat it. The only time you need a culture is when you haven't identified what the organism is. That's vulvovaginitis. Let's talk a little bit about cervicitis next. And cervicitis is a little bit iller, but because it's not that high of an infection, it's not that bad. It is primarily an inflammation of the cervix. And it can be caused either by gonorrhea, chlamydia, or by the organisms that cause vulvovaginitis. The patient is going to present with cervical motion tenderness and a mucopurulent discharge, but there won't be other signs and symptoms of PID. That is to say, in PID, you'll be able to also see a mucopurulent discharge and cervical motion tenderness. But the girl may not even know she has cervicitis until you do the physical exam. She might have some coital pain, but a lot of the times the girls don't even know they have this until you put your finger up there and all of a sudden it hurts a lot, where you put a speculum exam in and you see that it's all inflamed. So the diagnosis here can be made with a couple of tests, and you've got time to figure it out. The physical exam will show you that she's got cervicitis, but it's going to be a GC and chlamydia nucleic amplification assay, that's basically PCR, and a wet prep will differentiate the diseases for you. Now, what you should not do, because they have low yield, is use a gram stain. And cultures are generally very useless because you've got your wet prep and your net. If the test gives you gram stain information, that's useful. That is to say, gonorrhea is going to show up as gram-negative diplococci. Chlamydia will show up as lots of white blood cells, no bacteria, because it's intracellular. But that doesn't change your management, and it has low diagnostic yield, so you shouldn't do it. But because the gnat takes about 48 hours to come back, you often end up treating these people empirically. So if you're going to treat gonorrhea and chlamydia, you treat gonorrhea with ceftriaxone times 1 IM, and chlamydia is going to be treated either with doxycycline or azithromycin. And they really can't make you choose between them. Doxy is generally going to be the right answer because it's cheaper. Azithromycin causes cardiac toxicity. Doxycycline can't be taken if pregnant. So there can be ways that they throw a wrench in there to make you choose between them, but generally they should not. And in general, if you find one, you treat the other, especially since chlamydia is intracellular, doesn't show up on gram stain, and doesn't usually come out on culture. Usually you just treat them both. And if you see something else on the wet prep, okay, well, it's not either gonorrhea and chlamydia, and you can see it right then and there in clinic, you're going to treat based on the chart over here. So cervicitis is sort of that bridge between vulvovaginitis and pelvic inflammatory disease. The person isn't that sick, so you can use the wet prep and the NAT to figure out what it is and treat what you find. When it comes to pelvic inflammatory disease, the severity of illness is a little bit higher, and now they don't have time to wait for the tests. The path is essentially anything we talked about over here: salpingitis, endometritis, ovarian abscess, flank peritonitis. But what we know is that it is going to be an ascending infection. and it is caused by gonorrhea a third of the time, chlamydia a third of the time, and then vaginal flora a third of the time. That's going to become relevant when we start talking about empiric therapy. The patient is going to be sick, and the CDC has very specific criteria for what constitutes pelvic inflammatory disease, and then there are some other clues you should identify in a vignette or in your patient that say, hey, this person is a little bit more toxic. So diagnostic criteria go like this. There either has to be pelvic or abdominal pain. There has to be no other cause for those symptoms. And then any one of the following be positive. Cervical motion tenderness, adnexal tenderness, and uterine tenderness. Any one CMT, adnexal, or uterine tenderness, if you've got any of those that are tender, anything that involves the GYN organs, count it. Now the person is generally going to be more toxic because this is as high up as it gets, they're going to be a little bit more ill. And so what you should look for is a fever, lots of white blood cells on a wet prep, knowing that an absence of systemic leukocytosis does not mean absence of this disease. They may have no fever, leukocytosis, and still just be as ill. And they're likely to have a mucopurulent discharge. Now, the diagnosis of pelvic inflammatory disease is based on those criteria, so it's generally a clinical diagnosis. You can do a transvaginal ultrasound to help you identify a tubovarian abscess or free fluid. You don't have to do the ultrasound before you give antibiotics. And because this can cause death as well as long-term fertility issues, you really want to get this treated. The treatment's going to come in two forms. Either an inpatient form, in which case the person is severely ill, and this is not going to be based on the criteria, it's going to be based on your assessment of toxicity, nausea and vomiting, that is they can't tolerate PO, or they're pregnant. The inpatient therapy is going to be cefoxitin and doxy IV. This is where you want to go first. If for some reason you cannot give this because of allergies or pregnancy, then the backup regimen is going to be clindamycin and gentamicin. An outpatient regimen is ceftriaxone, IM times 1, plus doxy, plus metronidazole. You can replace ceftriaxone with cefoxitin and probenazid times 1. Now, I just want to identify what you're doing, right? So this is empiric. You have to memorize it. Cefoxitin and doxy. If that doesn't work, clinda and gent. But look at the outpatient regimen. Ceftriaxone IM is going to cover gonorrhea. Doxycycline is going to cover chlamydia. And metronidazole is going to cover anaerobes. At the very minimum, what you're covering is gonorrhea, chlamydia, and mycoplasma. And that ceftriaxone is going to have a little bit of gram-negative coverage. So you're going to get most of the organisms that could potentially cause pelvic inflammatory disease. Now notice what we did not use, which was fluoroquinolones. Fluoroquinolones are out. We did not use oral cephalosporins. Those are out. Resistance is too high. So memorize these antibiotic regimens, but also recognize what you're doing, which is treating gonorrhea, chlamydia, and some of the atypicals, and maybe even some of the anaerobes that can ascend into that area. The only thing you have to watch out for is, does this person need surgery? And surgery may be simple as drainage of a tubovarian abscess, as much as removal of the uterus, and then if there's frank peritonitis, maybe require a washout. Those are people who are sick, don't get better, or someone who finds free fluid on the ultrasound. This is actually a lot more complicated than it sounds. It sounds only like 3 diseases. This should be easy. For vulvovaginitis, it's going to be simple. Candida, KOH prep hyphae, use antifungals. Bacterial vaginosis, clue cells, use metronidazole. Trichomonas, flagellated organisms, use metronidazole. Everybody gets a wet prep, which is saline and KOH. Cervicitis is going to be inflammation of the cervix, generally caused by STDs. Patient's not that sick, but there is cervical motion tenderness. Pelvic inflammatory disease is going to be a person who is sick, gonorrhea, chlamydia, and vaginal flora. The empiric therapy is what you want to commit to memory, and then know that you might need to go to surgery if the person doesn't improve. That is gynecologic infections.